Yes.
Professor Thomas, I've some various questions, so we'll dot around from topic to topic because they've been identified.
Ms. Richards, could I just ask,
Yes.
in fairness to Professor Kernoff, who's dead, I've just read that paper again during the break, British Journal of Haematology, and I just wanted to make one other comment, really. And is it possible to show that again?
Yes, certainly.
Just so that people can see precisely what I'm talking about.
It's PRSC. No, that's quite right. PRSC 303439.
If we go to the patients and methods section,
Page 2.
and it's the it's the third paragraph down. Actually, it's on page 471.
Next
right.
page, please, Seamus.
Next page, then, please, yeah.
And did you say it was the third paragraph, Professor?
It's on that page. It's the second paragraph down, and particularly here, treatment was given either. I just wanted to paint the picture really, which treatment was given either to stop bleeding or as prophylaxis before surgery. During and dosage of therapy and choice of therapeutic product were influenced by clinical circumstances, local availability of products, and departmental policies which operated at the time. These changed over the course of time. So, just to make clear, these patients were actively bleeding or were just about to go into surgery for when it was known they were bleeding. And these concentrates weren't given electively, if you like. They were given as a method of treatment, or in the case of the surgery, obviously, in the anticipation that there would be bleeding. So they had to give exactly what was available, and then they determined what each patient had after the event. And the reason they did serial LFTs afterwards was what we alluded to before, and that was that just looking for jaundice after an episode of treatment would miss a large number of cases. And we already knew that post-transfusion hepatitis was occurring after use of concentrates and after single units of blood on occasion. And it was important to know in individual patients for their own clinical care whether they were one that was getting these problems. So the context was an acute bleeding episode or before surgery, in the context of knowing that liver function tests were occurring, abnormalities were occurring after use of these concentrates. And they wanted to record whether each individual patient had this, both for research reasons to see what the frequency would be, but also in terms of management of the patient, because there were lots of causes of abnormal AST. As I mentioned, non-A, non-B being the main one, but some people had hepatitis B, and there were other causes, chemical toxicity in the liver. So I just wanted to make those points really, because Professor Kernoff were here. I think he would point out that in the context of a bleeding episode, mistakes are made, and I think there were one or two, or at least one case I know of, where it probably would have been, if it was decided in a cool, calm, collected way, that the patient received cryo rather than concentrate. But he does say it's dependent on what's available, really. So that's all I wanted to say, really. And no doubt, as I said before, you've had a chance to talk to Dr. Lee about this. So,
yes, I think one of our difficulties may have been that Dr. Lee may have taken up a particular post at a stage when the study was well advanced. And a prospective study, if patients are enrolled in the prospective study at the start, one would expect the patients to be told then what they might expect later. So it was really the issue of consent that I was that's inspired the questions I asked. But I have to leave it there because Dr. Kernoff would have been the person to ask, and of course we can't.
Yes, yes. But I would just say, as I did say, he was a meticulous person. And he has written in the paper that the patients were appraised of what was happening, although I noticed some of them were 3 or 4 months of age, so it would have been the parents that they were talking to. But anyway, that's all I wanted to say on that. And as I say, it's the haemophilia doctors are the ones who would be able to give you more information. Although I don't want, I was involved with the study and I was involved in the discussion of it afterwards, so I don't want to argue that I wasn't involved. I was involved in what the cause of the LFT might be.
So unless you think it useful, I'm not proposing to ask Professor Thomas further. I've no doubt we'll receive submissions about this study in due course from core participants. Professor Thomas, in your statement, you say, and this is, if I just put your statement up on screen, it's WITN. I'm hoping you're ahead of me. 3824, you are ahead of me. If we go to page 6. Paragraph 12, you say, hepatitis after blood transfusion was quite common, 2 to 3% in the UK, perhaps 10% in the USA. Are you able to assist with what the basis is for the figures you've given there in relation to the UK?
I think the best study was the one that I alluded to just before the break, and that was that there was a study of cardiac surgery patients in Newcastle, and the senior author in that was Professor Oliver James. So if you put into NIH PubMed Oliver James, I think this should come up, and he calculated that, I think he said that on average people after cardiac surgery received about 6 or 7 units of blood. And after an individual unit, I think he thought it was about 0.2 or 0.3, something like that, if each unit of blood was calculated. Of course, the calculation was the other way around. I mean, I think he found about 2 or 3% had abnormal LFTs after cardiac surgery. And on average, they had 6 units of blood. So he computed that the number of infected units was, well, 2 or 2.5 divided by 6, which was about sort of 0.6%. So it's worthwhile pointing out, this is the hepatitis after blood transfusion. The number of infected units would be dependent on the number of units that we used in each transfusion, and he calculated that to be about 6. So if you want the incidence per unit of blood, it would be a sixth of between 2 and 3.
No, I was just trying to understand.
The US study was a basis. There was an NIH study, National Institute of Health study, at Bethesda, where I think that was, Jay Hoofnagel was involved with, and they were looking prospectively at doing ALT screens after blood transfusion, the percentage that were abnormal, and I think it was around about 10%. And the other name to pick up is Blaine Hollinger from Texas. He also did a post-transfusion hepatitis incident study.
We can take that down, thank you. The next question I'm asked to ask you relates to stage 1 Skipton decisions, intravenous drug use. How would you have dealt with a case where there was evidence to suggest that there was a route of transmission through transfusion prior to evidence of hepatitis C, prior to evidence of intravenous drug use, and then evidence of intravenous drug use post-transfusion? Is it the case that the record of intravenous drug use would still have been enough to lead to the claim being rejected?
I think if you could be sure that the hepatitis was noted before drug use, then of course you would say that it was due to the blood transfusion. But how you know when an individual starts using drugs is more difficult to determine, really. And since it is sort of addictive behavior, I mean, people aren't making open choices, really. They are addicted. It's difficult to know, when the various things started. But if it was validated, demonstrated incontrovertibly that the blood transfusion occurred and then there were abnormal LFTs and the drug use started later, then yes, that should have been adequate.
Was there ever, in relation to Skipton decisions, whether stage 1 or stage 2, a policy of deliberately delaying or deferring decisions in borderline cases to see if the virus would progress or clear?
No, I certainly didn't know any instances of that, really. Whether it was an acute episode where 20 or 30% would have cleared, or whether it was an established chronic episode where 1% might clear after 6 months, we never waited or just took it at face value and looked at the statistical probability, but the former was much more common than the latter.
Then, still with stage 1 Skipton applications, I want to ask you about this hypothetical scenario. If you had an applicant who was known to have had a particular operation, if there was evidence of, say, 10 or 20% of patients for that kind of operation needing a transfusion, and there was the applicant's recollection was that they had a transfusion, and there was no evidence of any other risk behaviour, so no evidence of IVDU or anything of the kind, on what basis could it be said that the claimed blood transfusion was not the probable cause?
If as I was the first person to look at this, and I estimated it to be 20% probable, I would probably have to turn it down. But if I was on the appeal committee, I would have let it through. So what I'm trying to say was that, the process we had was that where there was subjectivity, it should be applied at the appeal committee stage, and we should stick as best we could to hard facts in determining what should be the right way forward for the first step of evaluation.
Did you feel an obligation to the Department of Health or to the NHS more generally to limit stage 1 and stage 2 approvals, or take a more purist objective approach, given what you described in your earlier evidence as large amounts of NHS money having already been spent?
Well, as a scientist, I wanted to do what was right. I mean, I came into this as a volunteer after I was chairman of the advisory group on hepatitis, and I was asked whether I'd like to help with this, and I said yes. But I am also a clinician, and I recognise that throughout my career there have been major constraints on health care and funding of it. So I wasn't at all negative at the starting point over whether a person should get it. And indeed, in fairness to the NHS and the Department of Health, we were never limited on the number of cases that we could fund. If they met the criterion of greater than 50% probability, it was NHS, and then at stage 2, nobody ever said we could, recommend unlimited numbers for this. So that's the situation I took. But as a director of the Skipton, of course, we did get serial, at each yearly annual general, meeting of the board of directors. We were given figures as to how much had been given out and these sort of things. So whether it has a subconscious effect, I don't know, but we didn't consciously go into trying to limit the spend.
in relation to stage 2 assessments, if you had a form from the applicant's own clinician setting out their view that the patient was cirrhotic, was there ever a need to look behind that rather than trust the doctor most familiar with the patient's own diagnosis?
Well, it's partly dependent on whether in some occasions it would be a general physician who, although he might be a very competent, expert general physician, he wouldn't be an expert hepatologist. So, one looked at the basis for why that individual had come to the conclusion that it was a stage 2 triggering stage that the patient had reached. And just as you've asked me whether I came in with any sort of baggage, for want of a better phrase, of whether I wanted to save money for the NHS, I think most of the physicians filling in these forms really genuinely wanted to look after the interests of their patients, and they would be a bit like defending counsel, really. They would want to present the best case that they could. We were in a different position. We were in the position of having to evaluate it depending on the data that was on the sheet, not in terms of the person's opinion.
Next question is about natural clearers. To what extent has the updated medical knowledge about the effects of hepatitis C, which has come to light over the years since the Skipton Fund was first set up, suggest that there should be a reassessment of the exclusion of natural clearers from the schemes?
It was known right from the earliest days, back in 1989, 1990, that 20% or so of people cleared the virus as determined by clearing hepatitis C RNA measured by PCR, and then they were just left with antibody. If you found somebody with antibody but were RNA negative, the probability was, since after chronicity only a very small number would clear the virus, leaving antibody, less than 1%, statistically it was much more probable that it was an acute clearing in the first 3 to 6 months rather than a chronic, longer than 6 months of infection, clearing in the later stages. The latter would have, under the rules that were mandated by the Department of Health, the latter would have, the former wouldn't actually have qualified by the rules.
So is it your view that the position in relation to natural clearers has not changed?
I don't think it did. We had, RNA, so-called NAT assays, nucleic acid tests for the virus, direct measure of the presence of the virus, and antibody tests right the way through from 1991 to the present time. And that study that I mentioned in NIH, they were able to do sequential studies looking at whether there was a window period when there was RNA right at the beginning but no antibody, and then the transaminase rise indicating liver damage, and then a period when the RNA would disappear and the antibody would appear. So that natural history of the serology was evident in the 1991-92 period, and is the same present today.
You've told us about your research as regards the link between hepatitis C infection and damage to the brain, and indeed we've got the papers in materials to which you've referred. Are you able to assist with this? To what extent does that damage to the brain have an impact on the functioning of the whole body and not just on cognitive functioning?
We were able to say the virus was in the brain because we'd done this spectroscopy of the brain, and we've found the same pattern in hepatitis C as we'd found in HIV, which had previously been known to infect the brain. and in addition, there is a brain bank in Edinburgh, and they will give pieces of post-mortem tissue to you if you want to look for various things. And we were able to show the virus in the brain from those tissues. And the virus that we cloned from the brain was different from the one that we got from the same individual's spleen or liver. So that showed that in some cases it was in the brain, but in any individual before the patients, if they died, before we'd had post-mortem material, we couldn't say whether the virus was just in the blood or where it was in the blood and liver, and in addition in the brain. Do you think the question is related to the fact that, the brain might, if there was a dysfunction of the brain, could it cause blood pressure changes or things like that? Is that what you're thinking about? Or
it's a question I've been asked to ask, so I've no greater insight in it than the question I formulated. Damage to the brain may have an impact upon cognitive functioning. I don't know whether you can answer this or not. Does the damage to the brain that you identified have any wider impact upon the functioning of the body?
Not that we were able to demonstrate.
Next question relates, the next two questions I think relate to hepatitis B. As part of your work over the years on hepatitis B, did you come to any conclusion about the efficacy of the screening for hepatitis B that had been introduced in the early 1970s?
Screen for hepatitis B in the general population or in the haemophilia population?
I'm afraid I'm simply asking a question as articulated to me.
Yeah. Perhaps let's interpret it as in the context of infected blood. All blood was screened for hepatitis B surface antigen from the, discovery of hepatitis B, certainly in the 1960s. The most sensitive assays that were available at that time were immunoassays, whether it was radio or enzyme assays. That really removed most of the hepatitis B related post-transfusion hepatitis. It was fairly prevalent in maybe the 1940s, 1950s wartime period. But post the discovery of hepatitis B and the availability of radioimmunoassays against hepatitis B surface antigen, it was pretty much dealt with. And then we, just to finish, they then went into NAT assays, not nucleic acid test assays, where they look for hepatitis B virus DNA in the way that I've just been describing. You can look for hepatitis C RNA. And that meant there's virtually no hepatitis B post-transfusion.
I think that does answer the question, thank you. And did you yourself participate in any research to establish the prevalence of hepatitis B infection amongst haemophiliacs?
No. I think there was quite a bit from previous periods, the older haemophiliacs. And the other problem about determining prevalence was what we call passive transfer. So if you cryoprecipitate and concentrates contained antibody from the particularly the cryo, because it was cryoprecipitated blood, and you were passively transferring antibody to surface antigen or antibody to core. And that meant you couldn't tell whether they'd had an active infection or it was this passive transfer of antibody which was causing the positive in the antibody assays. But there was a lot, reading between the lines, without having solid data. I think there was a lot of hepatitis B in the haemophilia population from earlier periods before we screened for it.
And we've explored, I think, to some extent through the mechanism of the Kernoff paper, hepatitis C prevalence in commercial concentrates versus NHS concentrates. What about the position in relation to hepatitis B? Do you have any knowledge or understanding of prevalence of hepatitis B in commercial concentrates as opposed to NHS concentrates?
No, not in a comparative sense, but some patients did, some concentrates did transmit B as well as C. We wrote one such case up, and another concentrate transmitted hepatitis B plus delta and C. So there was all sorts of sort of carrier, there were all sorts of viruses in that concentrate, many of which we probably don't know about today.
And then the last question reverts to the Skipton decision making, in particular, I think, in relation to stage 1. You referred to you being a scientist, and you've used from time to time, I think, language of being sure, and not wanting to undertake a subjective assessment, which you left for the appeal panel, wanting to undertake a more objective assessment. Do you think it's possible that you may have been applying a scientific standard higher than balance of probabilities?
Well, I doubt it, actually, because the 50% probability was difficult enough to achieve in the absence of case notes. So we were really pushing the boat in favour of passing those. And I'm thinking about the times when we went to look for scars could the patient provide a picture of the scars, which might indicate they'd had an operation where there was a probability of majority of patients having that operation having blood transfusion. So no, I don't think I'm being too stringent with it. Although I claim to be a clinical scientist, I spent every day of my life spent seeing patients. So I prefer to be known as a clinician and a scientist.
So those are the additional questions that I'm proposing to ask.
Yes. Just one area that I'd like to explore with you, if I may, and benefit from your knowledge of the time. As I understand it, post-war, well, during the war and immediately post-war, as you've already told us, hepatitis was a well-known risk of transfusion.
Yes.
And at that stage, hepatitis A had not been identified. That took until 1973. Hepatitis B wasn't identified until the earliest, the Australia antigen, in about 1966. And hepatitis C had to wait until 1988 and then 1989 before there was any full record of what had been cloned in 88. So, am I right in thinking that what was then used to describe hepatitis was a very general term, serum hepatitis?
Yes, you're really correct. They talked about serum hepatitis and infectious hepatitis.
And infectious hepatitis was what we now know as A.
A and E.
And yeah, thank you.
Yes, but mainly A, you're right.
And B and C were serum hepatitis, in effect.
Yes. Yes.
So, before hepatitis B was identified, and the inquiry's note of screening was that it started in 1970 for some donations, in 1972 generally in the blood supply in the UK. But before then, presumably hepatologists, clinicians generally, had become aware of the nature of the hepatitis and what it might involve for the individual suffering from it.
Yes, yes.
And was it known then that in some cases the hepatitis was very slow to show itself? It might not have an icteric phase.
No, I think for a long time we thought and that would have covered the time after the war. We really took post-transfusion hepatitis or serum hepatitis as indicated going by jaundice, which is a very crude determinant, really. And
at what stage?
Although the blood transfusion service did some very good things, they did stick with that for a bit too long. They looked at jaundice after their transfusions when the Americans had reverted to doing transaminases afterwards.
I was going to ask, at what stage did transaminases liver function tests come in, roughly?
Oh, you mean as being available in every context?
Well, as being used to detect what problems of a hepatitic sort in the liver?
Oh, God, I don't know the answer to that.
We can find that out from somewhere else. But it was at some stage during the 50s, presumably, was it?
Yes. I think it would be before, probably before the war, actually. But they were still talking about serum and infectious hepatitis during the war, and there were some major outbreaks in the soldiers in Singapore area, really massive outbreaks, and it was deemed to be a major factor on who won any battle. A number of soldiers that went down with hepatitis, infectious hepatitis at that time because of the terrible conditions. It would be major proportion. And if you go through, my hobby is going through reading the wall plaques in the cathedrals. And if you read that, most of the, if you look at the casualties, which are looked at in the Boer War and all these, it would say, killed in action, I don't know, just for argument's sake, 10, killed by dysentery, serum infectious hepatitis, 100, so 10 times more. So the outcome of these wars was purely dependent on, how well they could keep their soldiers. Very few were hit by bullets or whatever else. So I think, they're very much aware of all this, and I suspect there were transaminase as well as just crude measures of jaundice being used at that time, although I don't know for certain.
And the nature of the hepatitis which might develop after transfusion, would that lead in quite a number of cases to cirrhosis?
Yes. The big issue would have been at that stage how many are due to alcohol. The fatty liver related to type 2 diabetes, which is in the next year predicted to overtake alcohol as the major cause of cirrhosis. Alcohol was, before the last few years, that was certainly thought to be the most common cause. Hepatitis B in the context of the UK was pretty unusual. But the Chinese, of course, as soon as the Australia antigen became available, they noted that 10 or 15% of their population were chronically infected with hepatitis B, and they had acquired it at birth from their mother. And since immunizing at birth, the incidence of primary liver cell cancer, which is in the Far East mainly due to hepatitis B, that has gone down massively once the hepatitis B vaccine was used extensively. And the main cause of primary liver cell cancer now, reflecting the fact that the major cause of cirrhosis, which is if you like, the pre-malignant condition, is now hepatitis C, because hepatitis B has been controlled by vaccination. And we still do not have a vaccine for hepatitis C. It's the same problem as we're having with this current pandemic. All of these viruses, hepatitis C and the COVID-2 virus, the SARS virus, they are what we call swarms of viruses. So with hepatitis C, there may be 10,000 or 100,000 virus particles, all slightly different in their genetic structure. And as the immune pressure comes on the virus, then one or two virus particles will find they have an advantage, that they can break through the natural antibody response or the vaccine response. And the same is true now of SARS. SARS-CoV-2 is too long a name. That is a mixture of different virus particles. And when you apply an antibody immune pressure to the virus, you will select out variants, which is going to be our problem with the current vaccines and CoV-2. One doesn't want to be too pessimistic about it, but I think that will happen. And we were able to show this in the context of hepatitis C by looking at A-gamma-globuliniemics. There is the envelope of hepatitis C varies massively over two hypervariable regions, two variable regions in the envelope. And this is in a person with a normal antibody response. But if you look at somebody with A-gamma-globulinemia, where they can't produce antibodies, then there's no variation in the envelope. So it's the patient's antibody response which selects out the variants, and the same will be happening with SARS-CoV-2. As we put different antibody pressures on the virus, you'll be selecting out different variants, and because we have a bigger proportion of our population immune now. Then we're selecting out different variants, and hence we had the distinction of having the UK or Kent variant named after us, where because we had a lot of vaccine, we're seeing variants come through. I must say, this is a retired armchair ex-virology clinician's view of the world. So,
well, just taking that same retired armchair clinician's view of the world. You mentioned a moment or two ago, and earlier you were asked by counsel questions about hepatitis B. You mentioned the effectiveness, at least so far, of hepatitis B vaccine. That, as we understand it, was introduced only as a universal vaccine for children in this country in 2017. Do you have a view, or did you have a view, as to whether that, in line with your views about testing for hepatitis C and surrogate testing earlier, should have been introduced earlier?
Well, it was introduced in the medical and nursing profession because it is the major incidence, I think, is related to blood contamination, either through needle use or because of sexual activity. And I think we do have an extensive program where people attending sexually transmitted disease clinics are immunized against hepatitis B, and that was something that came to the advisory group on hepatitis that I was involved with. And we pushed that really to get control of that mechanism of transmission in our community. But outside the sexually promiscuous and intravenous drug users, then the transmission of hepatitis B is not that great in the general population. And I think therefore, at the earlier stage, probably introducing hepatitis B vaccine wasn't cost effective. I think a lot of there is now a hepatitis A plus B vaccine, and I think, for instance, when university students are going on walkabout, on a gap year, then we recommend they're all vaccinated. And so as behaviour changes, then the vaccine strategies change.
Yes, thank you very much. That's all I'm going to ask.
So I should have confirmed that Professor Thomas's counsel has no questions that she seeks to ask. Professor Thomas, is there anything further you would wish to add to your evidence?
thing. Not really. I think I do think that I've had 3 different experiences as a clinician, really. This one on non-A, non-B, where I did get the impression that the NHS was short of money and was, trying to make it go as far as possible. And then, of course, I was on the new and emerging virus committee when the swine flu thing started. And there, the mathematical modelers said we were going to lose millions of people, and I think we lost about 18,000 in the end. The recommendation that I and others was involved in this committee was we ought to buy a lot of drug. There were 2 drugs which might work against flu, and of course that didn't come about, so the Department of Health bought a lot of drug that they didn't need. And then the most recently, I think, it's been a question of the vaccine versus drugs to treat people. And I happen to be working in a little biotech company, really, making drugs for hepatitis, making drugs for SARS-CoV-2 with Porton Down. And, again, the focus has been on vaccine and not the individual, really. But I think the driver to all of this is that we've never been particularly prepared in the UK because we don't have any spare capacity in our hospitals. And this isn't original. I mean, everybody has said this, and I think it was true right from the word go with non-A, non-B, where, treatment was expensive and there were financial constraints, and it's just the same true today, really. But otherwise, money is always the root of the problems, and I would like to see that we spent a lot more on the health service so that there was a better level of preparedness, really. But then you're going to say what you can not go spend money on, so that's that's a problem as well. But otherwise, I don't have anything to say.
Thank you, sir.
Well, you described yourself just shortly ago as a clinician first and a scientist second. I think certainly you've shown us a huge amount of both sides of what you have to say, but you also have indicated a third side, which is, I think, demonstrated by the lectures which you told us you gave from time to time, in which you explained some of the intricacies of science, and you have helped us to explore some of those intricacies in a clear and helpful way, and given us access to some of the information which, if I can say, it's probably filled a few gaps for me, certainly, and I'm grateful, very grateful for that. And you've told us, so far as the Skipton is concerned, given us the detail of how you saw your role and the way in which you applied what to a lawyer is familiar territory, the burden of proof on the balance of probabilities. So thank you for all that, and thank you for allowing us a day of your time. I think you've had experience of giving this type of evidence over a number of occasions. So thank you for being prepared to do it again and to help us in this inquiry.
Oh, thanks for being so pleasant about the whole thing. And I must say the chaps setting up are really very effective.
Well, we haven't, I think, lost any transmission from you. We've had the odd problem just recently, but only rarely. So I'm very glad that you have that to say about them. So thank you for that too.
Well, thank you, Sir Brian. Yeah.
So tomorrow, sir, we have the evidence of Mark Mildred, first of all, as chair of the Skipton Appeal Panel, and then we'll be starting after we've completed his evidence tomorrow with the evidence of Charles Lister as one of the Caxton trustees.
Yes, so
At 10 o'clock.
10 o'clock tomorrow.
Thank you.